Hmm. All right. Hello, everybody. So welcome. My name's Samantha Bellinger, and I am the program specialist with AIM and the PQC. And I'm happy to welcome you all to this installment of our webinar series. And so today we're going to have an introduction to care of pregnant and postpartum people with substance use disorder, our patient safety bundle. Next slide. All right, so before getting into the presentation, wanted to go over a few housekeeping things. So for the chat, we'll be monitoring the chat function. You are welcome to add any of your questions in there at any point in time. And if we don't end up getting to your question right uh, as you add it in, we will be able to address everything at the Q&A session.
Mhm.
And in addition to the chat function, we wanted to offer that if you would like to raise your hand, we will call on you and you can unmute and ask your question verbally. All of you should be muted upon entry. We're asking that you all stay on mute for the purposes of the recording. Um, and if you do wish to ask a question verbally, more than welcome to do so. And for this webinar, there are captions. So they are automated captions. You can find that in the toolbar below. Depending on your screen size and your device, you may need to go to the More section and you'll be able to activate the captions there. And finally, so we will be sharing an evaluation at the end of the webinar. And then you'll also receive a link to that survey in our follow-up email. So that will either be later today or tomorrow. So I think that is it for housekeeping. So next slide, please. And we have no disclosures. So wanted to start out with today's agenda and just set expectations of what we're going to be covering. So to start, we'll be introducing our speakers, then grounding our work, reviewing the AIM bundle structure, also reviewing some data from the clinical practice assessment that was recently done, as well as introducing the toolkit, so areas of focus, materials, things along those lines. And then also starting to wrap up with an implementation timeline, next steps, and then, of course, having some time for questions at the end. So next slide. All right, so I wanted to introduce today's speakers. The majority of you on this call have heard from us before, but today's speakers will include Dr. Marge Meyer, who is the AIM clinical lead, Dr. Carol McBride, who is the AIM data manager, myself, Samantha Bellinger, Kayla Panko, who is the AIM nurse educator, and Katie Leffel, who is perinatal nurse program coordinator. And I believe at this point, I'm turning it over to Carol.
Okay, so to lay the groundwork, you can actually go to the next slide, please. As we all know, substance use disorder in Vermont is a major public health concern. While AIM particularly works in the perinatal space, we have to address the fact that substance use affects all Vermonters. I would be surprised if there's a single one of us who has been personally unaffected, either through family, friends, or through our patient care. We spend a lot of time discussing opioid use because we have treatments available, but it is more than just opioids. In this figure, we can see changes in treatment by substance. Over the past 10 years, we've seen decreases in treatment for opioid use. In red, the highest line with the largest number of people. And the second line being blue in alcohol use. We also see a decrease in the number of people treated for cannabis, though this is likely indicative of changes in legal practice and less so in actual treatment practices. And then primarily of concern, we do see that bottom line with the increase, and that is for stimulants and other substances. So that includes methamphetamine and cocaine. So that is of concern with an increase over the most recent years. Next slide, please. So as we all know, substance use disorder in Vermont is a major concern. Whoops, I am actually on my wrong notes. Just a second. Okay, sorry. So in 2022 and 2023, this figure looks at treatment by type of substance use, just in the most recent years available, and what type of treatment, who do have substance use disorder, what type of treatment are they receiving? As you can see, the majority of treatment is received in the hub model using MOUD. Or outpatient clinics. Other types of treatment available include residential care, case management, and intensive outpatient treatment. And approximately 9,000 Vermonters per year receive treatment for substance use disorder. Next slide, please. Okay, so now that we'll go into the perinatal space, I'll turn this over to Katie Leffel.
Thank you. So I just want to take one quick moment to acknowledge the incredible loss associated with this data when we talk about maternal mortality in Vermont and the stigma and bias, particularly targeting the women represented in this data. And their deaths have really guided the health department in identifying key priority areas for support. So when you look at this data since 2012, when the panel was first reviewing maternal death in Vermont, 43% of perinatal deaths in Vermont were the result of accidental overdose, and this number is continuing to increase as a percentage of overall deaths reviewed as we go forward in years. And of the 8 maternal deaths reviewed by the panel since 2021, all were related to opioid misuse. So we're also seeing a shift in type of, the cause of death over time to being a majority, if not all, opioid misuse related deaths. The other thing I really like to highlight when we see this data is that the 6 accidental overdoses that we reviewed in the panel during one meeting in 2023, we reviewed 2 women who were stable in MOUD treatment, 2 who were not engaged in treatment and were flagged as high risk, and then 2 who did not screen positive for use and did not disclose use, and yet all 6 of them died in that postpartum period of an opioid overdose. So I just really want to emphasize that we don't know who's at risk necessarily, and we need to be universally screening and making all patients aware of community resources. Next slide, please. So this is looking at the timing of perinatal death or maternal death in Vermont. It differs from the national data, with Vermont seeing by far the vast majority of deaths happening after the birth up to 365 days, with that timing being particularly high when we look at that time after they leave obstetrical care, generally speaking. So that 43 days to 365 days, we're seeing the deaths happening primarily at home as well. So, just want to really emphasize that we're expecting perinatal people with substance use disorder to not only birth and parent their newborns, but also we're hoping that they're rebirthing themselves in this recovery process and really taking that time and effort. And it's a substantial added burden and stress to their lives. So really emphasizing that enhanced community supports are a key piece here. And we're all responsible for making sure that these women are connected to resources. Next slide, please. This is a slide looking at newborns exposed to opioids and the birthing parents' treatment in that pregnancy period. So what you're looking at here is over 5 years, the gray being not engaged in MOUD treatment, and then the lighter blue, the buprenorphine, and the darker blue, methadone treatment. Of note here is that over half of the opioid-exposed newborns born in 2023 were born to people who were not engaged in treatment. So this is an increasing rate of birthing people with substance use disorder who are not engaged in MOUD treatment during pregnancy. So that is not the trajectory we want to be seeing. Next slide, please. This is looking at the partners in this work, just emphasizing that The Perinatal Quality Collaborative Vermont has been engaging in long-standing partnership and receiving funding from the health department, as well as long-standing partnerships with UVMMC, community hospitals, and many community-based organizations. And we're all working really hard to make this all possible. I think I'm turning it over to Kayla now.
Thanks, Katie. So part of our group wanted to just kind of map out the things that we've been working on prior to coming to this webinar. And it's hard to capture all the different things because there's so many buckets of projects and overlap. Like Katie said, there's so much collaboration happening. But this is just a little glimpse of what we are working on in 2024 in preparation of this implementation of this bundle. And one thing we really want to highlight was our work building a patient and family advisory panel through the PQC. Because as we all are probably very familiar with, those with lived experience bring such a wealth of knowledge and information to the work. And we really wanted to make sure that was part of our processes in all of our projects, including this bundle implementation. So we started recruitment in April. And then we did a lot of work onboarding and making sure our advisors felt prepared for their role, because there is a lot of prep work that goes into it, especially for those who have recent births and maybe some trauma or some experiences that didn't go so well. So we wanted to make sure they were fully supported and integrated into our teams. So that's what we spent the majority of 2024 on, and we are lucky to have 13 active members right now working with us in this work. So 2025 will bring more integration specifically into bundle and project work. But we just want to make sure that we highlight that because we view them as very, very valuable to our team and to this work going forward. And now I'm going to pass it over to Dr. Meyer.
Hi guys, I'm here in labor delivery, so if there's background noise, that's what, if there's background noise and I apparently can't access my camera, can you hear me?
Yes, we can hear you.
Okay, great. And I can't manage my slides. I'm on my phone. So you can go to the next slide. I just wanted to remind people that as with all the AIM rollouts, this particular package does have the similar structure in terms of the 5 R's, which you should be familiar with by now: readiness, recognition, prevention, response, reporting, and respectful and equitable care. What's different about this one is the integration with community resources, and that's why you'll see that this bundle is going to be rolled out very differently, because there's really much less medical kind of rollout than there's been with the prior bundles, and much more integration with community services, which I think everybody on this call knows is a bit more challenging. It's different within every single hospital in terms of how things are going to be integrated. Katie has been really super helpful in trying to integrate and to smooth out some of the siloing of the community services in the state. But we just wanted to acknowledge how uniquely complicated this particular bundle is. And then that's on top of all the work that we have to do with creating a family care plan, formerly known as Plan of Safe Care. So we are trying to pull all that together, and over this year, we'll develop different tools and different mechanisms, but each hospital is going to have to do substantial work to connect within their own communities, because not every community is the same. So the next slide. Is the next slide up?
Nope, sorry, there you go.
And this just gives you an idea. As with all the AIM bundles, there are outcome surveillance measures, and we will follow them. But again, they're less concrete, perhaps, than the other ones are. And I'll be honest with you, for us, I think the main issue is going to be how well connected we can be with making sure that our community service protocols that we're developing actually work. So we will be reporting these back to AIM, but I will tell you that for us in the state, we're really focused on making sure every community has a sustainable mechanism of community services engagement and communication. So the next slide, please. And to that aim, we have talked about some various toolkits. It is going to include, as we have given you before, a various number of components, and these are going to be developed as we develop this community services structure. But we're hoping to provide you with algorithms, pathways, checklists. If you need an EMR built to facilitate that, if you need to connect with specific services, how do you do that? So we are committed to helping everybody create their own path. And again, I want to emphasize the sustainability, because I think all of us have recognized that things that have worked in the past have often been reliant on one person or one pathway, and those things are not durable. Next slide, please. Great. And who's doing the clinical practice assessment?
That's me.
Awesome. That's what I figured. So as usual, I'm around for any questions.
Thanks, Marge. So before we jump into like the different topic areas that we've identified within this bundle, we just want to bring a little, we want to do a little bit of a assessment. We know this has been done before, but with COVID, so many things have changed with so much turnover. There's always change. So we did reach out to get one perspective from the different OB clinics across the state. This is an area that we haven't collaborated with as much because the first two bundles, hemorrhage and hypertension, were very hospital focused. So part of this bundle is allowing us to build more relationships, as my colleagues have spoken to. So it's been really exciting work. So just wanted to share a little bit with this. So we started in October, and as of this week, we had identified 16 clinics throughout Vermont that take care of perinatal people during that perinatal period. And we had 12 out of the 16 respond, with another 2 that are working on it this week. So far we have a 75% response rate, and the results will show that, and we'll update these as we get those final 2, but then all of our areas will be represented, which is really exciting. So we, as Merge said, like the 5R structure is still the structure that we go off of and that AIM presents to us in this bundle. But what we realized when we went through this is the majority of things are in that first R, in the readiness, because there's so much prep work or so much wraparound services to provide these families and these patients for the specific topic and condition. So we kind of broke it up in different ways based on how we thought we could implement change throughout the state. So our first section that we are looking at is screening and testing. And when I do have some data from that clinic assessment, I'm going to bring it into these different buckets. So this was one of our first questions is screening, and happy to report that 100% of our practices report screening perinatal patients for all of these different types of conditions: tobacco, alcohol, cannabis, SUD, mental health. We broke that up in a couple different buckets based on what some of our colleagues would like to see for some initial data: social drivers of health and interpersonal violence. This graph shows the timing of the screen. So as you can see, the majority of the screening happens in that first or second prenatal encounter with a patient at very high levels, 80 to 100%. And then this is just a comparison of looking at that first prenatal appointment and the percentage of universal screenings, and then in the postpartum. I would like to note that this is specific to clinic practices. So we know there's a variety of ways that patients get screened throughout their perinatal period, including home visiting, who does robust screening, different, if they're already engaged with different types of services, mental health counselors, like there's other screenings happening. We're not saying that they're not, but this is from the OB clinic standpoint of when they're performing the screenings. So just looking at the differences between that first prenatal appointment and then the postpartum. So I think making sure we wrap patients around in different services that follow them through that postpartum period is so crucial and a big driver of our work. One thing that we didn't mention yet, but with the data that we shared today, is we realized that there is actually a huge gap in the data that we can collect in the state of Vermont. So that is a big initiative that is being looked at, is like, how do we centralize data collection and how do we have a better representation for substance use in Vermont in the perinatal period. So we didn't have a ton to share with you, but just wanted to share that piece. And in regards to the tobacco screening, for the first prenatal appointment being one of the lowest screened per this assessment, it's surprising in the sense that from the stats that we can collect from the birth certificate data, approximately 356 pregnant people per year use cigarettes, but 36.5% of them reduce their usage in pregnancy. So the messaging, the education is getting there with seeing that drop in usage throughout pregnancy. Okay, so with each focus area or bucket of information, we're going to have different areas of focus and then drafted toolkit materials, because like Dr. Meyer stated, we know it's not going to be a one size fits all for everybody, but we want to be able to provide tools so people aren't reinventing the wheel and doing very similar things in different areas of our state. So we want to be able to support by providing things that are already created or things that we hope will work with little modification from the majority of our regions. So in this section, which does tie back to both readiness and recognition and prevention in the AIM bundle, NIDA and screening tools, biochem testing, adult and newborn. So looking what are the current recommendations and what do we have for reference materials already in place for facilities that are already acting towards or income. I can't think of the right word, in leagues with the evidence-based practicing as it stands now, related infectious disease testing recommendations, referral pathways, which will be huge and overlaps in so many different ways, resource mapping, and then also looking specifically about like what is different for this patient population throughout their prenatal care and how can we highlight the things that will make them the most successful for receiving prenatal care for their intrapartum stay and then for postpartum. Another huge bucket that a lot of it fit into the readiness was patient education. So many things tied back to making sure that the patient and family are informed of all of these things. So this was our first go around of the areas of focus. So making sure that there's reference materials as to why MOUD treatment is so important in pregnancy and what does that really look like, kind of do a little bit of myth busting around that. As Marge spoke to, the family care plan, which is the newly termed plan of safe care. There's a ton of work going on with that, with Katie and her team at VDH and Dr. Michelle Shepard and the ICONS team through PQC. So there's a lot of collaboration going into that, and that will be a whole thing in itself. What to expect at delivery, that's a lot of feedback we've received from people with lived experience, is just the unknown. So how can we make people feel better prepared going into delivery? And some of our community hospitals do a really good job and have different models of that. So wanting to highlight those and see if they can be replicated in other areas. DCF reporting, as we know, is always a hot topic around substance use. So really understanding what are the laws, the requirements, the mandated reporting around DCF reporting. And a big part of readiness in the AIM bundle is universal postpartum naloxone distribution. That will be a big project. Some of our hospitals already do this, but to implement that statewide is going to take a little bit of time. But there's already lots of materials out there, and luckily, it's usually not hard for patients and families to find different naloxone distributing sites in Vermont. But adding that extra layer of universal postpartum distribution will be one of our goals, but probably more in the 2026 timeframe. So toolkit materials that would support these things would be one pagers for clinics to be able to hand out to patients. The family care plan toolkit will be ideally its own kind of website page that gives both patients and families and providers access to those tools. Icon has shared before the One Care notebook and the hospital prep video, so making sure everyone has access to those. DCF, or Family Service Division, already has a ton of resources on their website, but just making sure that they're known and available to people. And again, trying to figure out those myth busting scripts to use and to share. And then the naloxone will be a 2026 project. Obviously, with patient education, we can't not have provider and healthcare professional education. So a lot of education focused in this bundle for sure. And this is hitting our readiness and response categories of our 5R structure. So while there'll be a lot of repetition of like what we have made for the families, will also need to be known to providers and staff working with families. But then there's some focus on clinical management, especially in the inpatient period, regarding pain management, initiation of MOUD for active use, postpartum follow-up planning, nicotine replacement in the hospital, things like that are all suggestions and things that we're looking into. What was mentioned before with like the core measures, sometimes our offerings, like last fall, we offered trauma-informed care, and we have recordings and modules available to continue that work. Stigma and bias is another kind of global topic that comes up that we will be providing education on, as well as informed consent. So materials look like checklists, look at maybe dot phrases or notes that can be built into your EMRs, example checklists or protocols that can be used, and then webinars and online modules that can be used for specific topic education. And we don't want to forget another group of people. So community-based partner education. So this is a project led by one of our PQC colleagues, Kim. And this is Bliss. It's a new project, bidirectional learning for improved support and services. And this is an initiative to focus on partners in the work who are already working with perinatal people, but may not have the background or knowledge or education that's specific to the perinatal space within SUD. So this is very important as it is bidirectional, because we want to learn just as much from these partners, such as turning point centers and doulas in the community, and all these different people who are already working with perinatal people but may not have this connection with SUD. So we have a one-pager up on the PQC website, and it's the conceptualization and the building of the materials is being done, and then offerings will be coming out in early spring of 2025. We can't get through a bundle without protocols and guidelines, so that makes its own bucket. And we kind of just broke them down based on these areas of focus of the phase of care, and then the big topics such as reporting DCF. So as you can see, like there's a lot of repetition and a lot of overlap throughout this. So this specifically speaks to readiness and response. Again, that readiness 5R keeps coming up. So a lot of it is built into readiness. So we realize it's repetitive, but it's nuanced too. So just want to bring attention to that. And then I'm going to have Katie take over this section.
Thank you. So I'm going to talk about community linkages and referrals, and I'm just going to take a moment here to adapt a Anne Lamott quote, when she's talking about grace and recovery, but I'm going to adapt it for home visiting, which is that I do not understand the mystery of home visiting, only that it meets us where we are and it does not leave us where it found us. So I think that's just a really important piece around looking at community partners, is they come to our families and they don't leave them where they found them. So, all right. So next I'll dive into the next slide here, which is the, oops, sorry, I'm getting referral, the piece around referrals and the clinic assessment data that Kayla was referencing earlier. So we're looking here at when referrals are made to community partners from the clinic, the obstetrical clinics. So looking at this, it's like lots of graphs here, but the referral timing is a little bit all over the map. But a substantial amount of the referrals are made in the postpartum period currently is what we're seeing here. So that's on the far right there. So we really want to see that backing up to the left and having a substantial amount of referrals happening in the prenatal period here. Next slide, please. And then this one is looking at how the referrals are actually made currently from the clinics. So there are at least 6 different roles we found making referrals in clinics. There are differences across the state in the way clinics operate around the referral process. And unfortunately, as we all know, there's also a high turnover rate for staff. So we really want, and Marge referenced this earlier, we really want practices to be able to identify which role is responsible for certain actions so that that referral and screening isn't connected to a single individual. We can create some sustainability and continuity here. So, and you guys will receive these slides and be able to dive more into all the different colors and what they mean. All right, next slide, please. This is looking at the opinions on so feedback from staff around how they feel about their current referral and feedback systems, how well they feel like they're functioning. So again, really wide spectrum of opinion here on the efficacy of the systems across the different locations. We can really learn from those who rate their systems in the 90s. So we'll be going back to talk to those clinics and understand what they're feeling like that referral system is working really well, and their feedback loops with their community partners as well. All right, next slide, please. So this is looking at some areas of focus and then some of the toolkit materials around the community linkages and referral piece. So as mentioned earlier, we're really looking at the prenatal family care plan, used to be called the Plan of Safe Care, and using Help Me Grow as a sort of referral hub for those referrals, and having the family care plan, when possible, be filled out with community partners, the home health agencies and Strong Families Vermont home visiting nurses, so that they, and we can do that in the prenatal period, so the family and the home visiting nurse are developing their care plan together. And then also developing those feedback loops we all hear so much about, and really want to make sure that there's really good communication between the community partners and the obstetrical care and the clinical care. So really looking at how we can support and develop that. And then each obstetrical practice and hospital having a template that refers to local resources so they can kind of easily access that information when they're talking to their patients. And then the toolkit materials needing to be developed is the EMR referral template, so your electronic medical record templates, as well as when we can't use the EMR for the referrals, what does that look like? What's that pathway look like? Scripting for providers, so they feel comfortable talking about these services, as well as scripting for the home health agencies when we're in the nurse home visitors, when we're talking about family care plans, so kind of helping support the way that they talk about these pieces of care coordination with families. And then family care plan toolkit, so that we can roll that out across the state in a standardized way, as well as some regional resource mapping. And I think that the next slide is back to Kayla.
Yeah, so that sums up like a portion of the things we've been diving into and exploring in this bundle, because there are so many components and there's so many partners in this work. So we've tentatively mapped out, 2025, what our AIM-PQC work looks like. A big part of it is going to be around that family care plan, because that is a big bucket of work that ties into so many different things. Separate but connected is, the CAPTA notification. So we are building electronic ways to be able to document these instead of resorting to fax. So the CAPTA notification process is going to be our first to pilot out of this. And we're hoping to start that pilot in February for UVM. We're going to do that at UVMMC for sheer numbers to make sure that our form that we created is working. The data is coming through de-identify like it's supposed to, and kind of work out all those kinks. But at the same time, we'll be hosting focus groups on the CAPTA and the family care plan for those of you who are the ones to complete those, because we want to come to you with our ideas and what we've been able to construct so far, but get the feedback of how will this work in your area? What won't work? What do we need to adapt? Who wants to help pilot this? So there's still a lot of work to be done, but we wanted to come to you with things already thought out and tangible things to look at. So those focus groups will be scheduled in the next couple of months. And then Bliss Initiative, like I talked about, curriculum rollout, that's scheduled for March, and that will help tie in more collaborative partnerships with areas that we haven't worked with before. Let's see, always want to give a plug for the Icons Conference. That will be in May, and that save the date, I believe, will be coming out shortly. And that's work that always kind of overlaps and ties into all of this work, because we're all working together. Okay, I'm gonna hand it over to Sam.
All right, thank you. And before I jump into next steps, I just want to recognize that there is a wonderful question in the chat, but since we're 2 slides away from the questions section, and it looks like that will bring up some really wonderful conversation, I'm going to do these next 2 slides and then we'll address that question. So for our next steps, as Kayla had mentioned, a lot of our planning is tentative. So we just wanted to tell you about a few of the upcoming things that will hit your inboxes fairly soon. And the first is our webinar schedule, so that we do have a series of webinars planned for the next several months. With changing landscape, and we do need to adjust a few of our dates as well as move some of the topics around. So we don't have our concrete sign up exactly for all of these next 3 webinars that we had hoped, but you should plan on hearing from us very shortly with those, and so they will be around SUD as well as the related more general topics such as stigma and bias. And as Kayla already mentioned, the focus groups and sessions around some of the specific topics and initiatives. And so we will have open call to everyone to weigh in on those. And then also, I believe earlier had mentioned that we do have trauma-informed care online modules available. So this is in continuation with the trauma-informed care trainings that happened in the fall. So if you have interest in those, please reach out to our team. And then I also wanted to say thank you to the nurse managers that also gave us a tentative headcount for some of those. So please know that we will be in touch shortly with more information on all of this. So next slide. And of course, our team really loves to make sure that there is some action items and know what you all should expect. So the first is data collection. So the revised AIM data collection surveys Marge had mentioned earlier is that those should be distributed shortly. I believe that they'll come out in the next week or so. Just a heads up that they will be going via RedCap, and that there are specific people that are already designated in that system. So if you know that your data collection person has changed in the past, couple of months, please reach out and let us know so we can make sure that it gets to you. The next ask is to just make sure that you all are providing universal screening, and just take a look and identify any gaps that you might notice, and then let us know how we can help you address those. It'll be good to have that in your mind. And then also, if you haven't done so already, or if you need to recheck net with turnover, please just identify the team members that will be working on this, or who are already working on this. Okay, so next slide. And we are on to questions. And so I wanted to see if, Amy, are you willing to come off mute and read your question?
Sure. Sure. Hi. Um, so yeah, a lot of great focus on the prenatal and immediate postpartum hospital stay. Just wondering, because our mortality shows that, within the 43 to 365 days postpartum is our highest rates of mortality. And 52% of those parents we're finding with infants born with OEN are not involved in MOUD. How do we get, I think the question that ends up coming is, what we see out in the community is that families just, they're very hesitant to engage. So how do we get these families to feel safe enough to engage in services without anxiety and threat of consequence due to their history of and use? Because I think there's a piece that, prenatally is one thing, postpartum is a whole other ball of beans. And if we can get them engaged in pregnancy is one thing, but what we're seeing is that we're not reaching the amount that's out there. As I do outreach in some of our recovery centers, there's a lot more that are being served in the recovery network that could be accessing our perinatal services in the community. And we all know that, I think we also know that some of them are hesitant to get prenatal care, and are very nervous to deliver in the hospital because they're afraid. And so that's been the question I've been asking, because is there a focus on that as well? I mean, I know there's some focus on it already, and we've been doing the work, but just kind of that clinical and non-clinical pieces of it.
And I see that Dr. Meyer has her hand raised. Is that to take that question?
Well, it was related to it, and thank you, because I agree with you 100%. This is the central question. And if you look at our data, going back to when we first started prescribing, which for us, it was in 2006, it used to be our non-treated rate was less than 10%. Well, less than 10%, in fact, less than 5%. And now that's 10 times more at 50%. And you hit on the exact right thing. And I think it's trust. And one of our biggest problems, honestly, has been how mandatory reporting has percolated through our patient population and what that means to them. And sadly, the only good approach I have would be to do what we can to earn the patient's trust back up, and hope that those same mechanisms that made them become to not trust us will actually percolate through the community so they know that they can trust us again. I think it is much more difficult now with the mandatory reporting. And I was going to add, and the reason I had my hand up was to add how difficult mandatory reporting is now, given the fact that we're all going to have to take a very hard look in the mirror about whether or not we're disclosing too much information from the medical community into community services, what we might need written consent for. And honestly, every time you have to get written consent, that becomes a barrier to referral. And as we develop these toolkits, we're going to have to take that into account, because I feel like that has become more acute in the last few months. And I think it may only get more difficult. So I do think that we have a large road ahead for us. So The one concrete thing that I can say, though, coming back to this issue of our problem that's happening after 6 months, is our transitions from birth into somehow some durable part of the medical community or the treatment community, or I think even peer recovery is probably going to be our best bet, because it's not going to be in the OB or necessarily even in the peds department. So sorry, that was a long answer, but thank you.
Thanks, Amy, for that. And I think also speaking to your point of, you're doing outreach in the recovery areas and how we're missing clients there. And I think that's part of our hope with the Bliss Project, is to build those connections and build their awareness of the other. Oh, Kim's on. Great. I say Kim can speak to it better than I can. Yeah, I'll leave it to Kim.
Yeah, so I'll chime in quickly. And I was just going to say, Amy, that it's just a huge focus of what we're trying to do with Bliss is make those connections. So to bring in, I have meetings set up with FSD later this week to try to get their perspective, and to really try to sort of like knit together, a story to address that fear. Because having met with the community partners that I have so far, that's just the overwhelming feedback that we're getting, is that is the number one factor there. So it's what I'm trying to do with Bliss. And Amy, maybe you and I can set up a time to sort of connect and review, what we've done so far. And I'd love to get your input and get you involved. And I see lots, Katie's hand up and everybody else. So.
Absolutely, Kim, anything to help.
Go ahead, Katie.
Yeah, Amy Wengers will be a great resource. She's got a lot of experience in this home visiting world. I put in the chat, but I wanted to say it out loud for the people watching the recording later. I feel a key piece of this also is that nurse home visiting should be presented as a standard of care in their OB care as well. So it's not like we are, it's some other service that might be helpful. Like, this is an expected part of your care, because part of what we also know from the nurse home visiting, the evidence-based data that we've collected over multiple decades, is that it takes not only a trusting relationship, but many, many interventions of screening and conversation and hours of time for the nurse home visitors to have that patient or that client feel comfortable disclosing things like intimate partner violence, substance use, all sorts of different topics that we screen and support families through. And so that's the other key piece, is that we need to be talking about this as just a part of their OB care and a standard of practice that's, and so it's not like a targeted extra thing that they need, but it's just like, oh, this is what we know works well for families, and present it that way. So I would love to hear more from our audience.
I'm scrolling through some of these comments, so some really wonderful suggestions of webinars, or not necessarily being taught by a group from the state, but also by peer clinical consultation. Let's see. Okay, so I see from Dr. Siegler, would you like to come off of mute and ask your question?
Yeah, of course. Yeah, so I wondered if there were any thoughts with this bundle about creating kind of a statewide general consent for urine drug screening. Because I've noticed in my past institution and here at Rutland that it seems like oftentimes patients aren't truly given an informed consent about, what happens if positive testing is found, or what if they decline testing, or if they're not offered urine drug screening prior to delivery, there's cord testing that seems to be done without necessarily the patient's understanding that that's occurring. So I wondered if there were any thoughts about creating a general consent for urine drug screening.
So I'll tell you, this is Marge. This is a great idea. And as we create documents to share, we have a lot of documents that we offer up templates for. And That way you can use them if you want, you can modify them or whatever, and we can absolutely add that to the list. And by we, I mean Sam, can you please note that? And Kayla, because I think that is, you're absolutely right. And if you have a template that you like, please send it along.
Yeah, I helped with creating one at my old institution. I can track a copy of that down and send it to you.
That'd be great. Thank you.
Awesome. We love stealing.
We shamelessly steal and share. And one thing I realized I didn't say that I wanted to make sure is we are really trying with all of our patient-facing education, trying to make as much of it universal as possible because of the unknowns or the potential use for down the road. So really trying to also limit that stigma and bias of it like being this focused, super focused on this one patient population when we know we're missing people. So let's make it universal and really try to make sure everyone has the same access to the same information. That way, if they come across it for themselves or a loved one, that they have the tools and know where to reach out. Is there anything else, Sam? I can't see the chat.
Yeah, so it looks like I guess this really more a conversation for Jenny and Katie. So Jenny, do you want to come off mute and say a little bit more about home visiting not always being available?
Well, it seems like, hi, it just seems like it depends a little bit on insurance. So that's one thing. So you can't really say it's a standard of care, but oh, wait, you don't have the right insurance. So, or we actually have to, like, they might have, it might be manageable, but like, we're not sure. So yeah, we can't really say this is part of standard of care, but yet only if you have this kind of insurance, and we don't know yet until they take a look at it. So I don't really see how we can say both. We could say, we'd like to offer you this, this might be really good for you and we're happy to connect you, but we can't say, yes, you can have this. It's part of our standard of care when we don't know if, insurance is really going to cover it or they're going to be eligible. Does that make sense? And maybe I'm wrong, but that's what my understanding is.
Yeah, Jenny, this is Katie jumping in. Thank you so much for bringing this up because this is always a topic of conversation, right? What is the capacity? How do we serve families across the state? What does it look like? And I think, there's a couple of pieces, there's lots of pieces to your question, your comment. And one of the things is that, particularly with opioid use disorder, by far and away, the majority of these patients are going to have Medicaid, in which the eligibility is really clear for home visiting services. So I feel like if we're talking about a particular subgroup, we can pretty confidently ensure that there's some sort of services available for them when there's Medicaid insured births. So I think we need to kind of think that in that terms. And I think the other big piece is we need to be able to look at these gaps and document them so that we can understand and make a case for what it is we need as a gap, right? Whether it's doula services, whether it's universal home visiting, whether it's, all of these different pieces. It's really difficult right now to say and understand where those gaps are and where our capacity issues are, because we don't necessarily always know that. So, and I'm not saying we need to solve that immediately, because that's a big, huge project. But I do think that there is a piece with this capacity that we need to understand a little bit better. And also, how are the communities teaming together when there are capacity issues? So how are we holding families between the services to be able to serve them until there becomes space available in a specific program? So lots and lots of work to do with the community partners too.
How would be the best way to document this or communicate it, and to whom? And
all really great avenues for exploration, Jenny. I think that we just need to think about that together.
Yeah. Okay. Well, thank you. Thanks for talking about that.
Excellent. And there's another comment in the chat that I want to at least verbalize for anyone who can't see it. So the Policy Center on Perinatal Mental Health. Apparently had a great webinar last week on topic last week. So if for anybody who is interested, then the recording is likely online somewhere. I promise I will try to locate that as well for any follow-up email. And in the last few minutes, is there any other question, comment, suggestion? All right. So in that case, then just want to say thank you to everyone for joining today. And so please know that this recording will be available to all of you as well as all those who have registered. I will be sending out an email later today or early tomorrow with the slides, as well as the webinar evaluation. I'll also put the evaluation link in the chat. And then also know that this webinar will be posted on the PQC website, and I believe Julie had posted that link in the chat earlier in the webinar. So again, thank you to everybody for coming, and if you have any questions, please reach out to any of us on the team. I will also make sure that all of our emails are in that follow-up email. So thank you.
And if you're interested in any of the work, please reach out. We love help.